All right, let's jump right into this explainer. This is tailored specifically for postgraduate physiotherapy students, and we are focusing entirely on the high-yield, exam-relevant evidence for medial collateral ligament, or ulnar collateral ligament, sprains of the elbow. We aren't doing a generic anatomy review today. We are getting straight to the clinical data and the evidence-based practice you need for your exams and your upcoming clinical placements.
So here's our roadmap for today. We'll start with the context and evidence limitations, then look at non-surgical management evidence, followed by surgical management evidence, and wrap it all up by building a solid treatment plan.
All right, part 1, context and evidence limitations. Before we even think about treatment, we've got to get real about the evidence base we're actually working with.
Here's the kicker, right off the bat. There are absolutely zero randomized controlled trials for managing elbow MCL sprains. None. And there are no studies directly comparing surgical versus non-surgical approaches. So what are we basing our management on? Well, we have to lean heavily on clinical reasoning and lower-tier evidence, stuff like retrospective studies and case series. And you really need to remember this. Almost all this data comes from overhead-throwing athletes. We're talking baseball pitchers, football quarterbacks. You've always got to keep that demographic bias in the back of your mind when you're extrapolating to the general public.
Moving right along to Section 2, non-surgical management evidence. Now let's look at the hard numbers, because these return-to-sport metrics are absolutely crucial for your exams.
Check this out. In one retrospective study looking at quarterbacks with impact-related MCL injuries, a whopping 90% successfully got back to their sport. And the timeline? It's surprisingly fast. They were back in an average of just 27.4 days, with the range spanning anywhere from 1 to 17 weeks.
But hold on, because a separate case series paints a very different picture when we look at general throwing athletes. For them, non-operative management only had a 42% return to sport rate, and it took way longer. We're talking an average of 24.5 weeks, stretching out from 13 up to 54 weeks. It just goes to show how the specific mechanism of injury and the demands of the sport completely change the prognosis.
Now, what about baseball pitchers? For them, non-operative management gives us a 66% return rate. But here is the massive caveat you cannot forget. 88% of pitchers who had high-grade or distal tears actually failed conservative management. That is a huge failure rate for that specific subgroup and pathology, which should heavily influence your referral criteria.
So how do we actually manage this conservatively? Well, it follows a pretty standard two-phase protocol. Phase 1 is strictly about tissue healing. You're looking at strict rest from throwing for 2 to 3 months using NSAIDs, icing, maybe some splinting, and sticking strictly to active or passive range of motion for the flexors and pronators. Then, around the 3-month mark, but literally only if they are completely pain-free, you move to phase 2. That's when you ditch the splint, ramp up the upper extremity strengthening, and start a throwing progression.
Okay, Section 3, Surgical Management Evidence. Let's flip the point and see what the data says about surgical reconstruction, leaning on the well-known Vitale and Ahmad systematic review.
According to that systematic review, a solid 83% of throwers actually make it back to their pre-injury level of competition after surgery. But you really have to manage their expectations on the timeline. It takes a long time, usually 10 to 26 months to return. And the post-op rehab itself, that's going to span anywhere from 4 months up to a full year. So yeah, definitely not a quick fix.
And we can't ignore the risks. The overall complication rate for this surgery sits right at 10%. And within that, ulnar neuropathy specifically makes up 6% of those complications. That is a very specific, very real risk factor that you absolutely must bring up during shared decision-making with your patient.
Vitale and Ahmad give us this really clear piece of guidance to anchor your clinical reasoning. They basically say the decision comes down to 2 main things: the severity of the tear and the amount of valgus instability. So, partial tears, those lean toward conservative management. But complete tears with significant valgus instability in overhead athletes, that's when surgery really needs to be on the table.
All right, let's bring it all together in Section 4, Building a Treatment Plan. Time to synthesize this data into an actionable, step-by-step conservative pathway you can actually use in the clinic.
First things first, your foundation is immediate advice and education. You're starting with the RICE protocol for pain management, advising on anti-inflammatories, and making it crystal clear that strictly resting from that aggravating throwing motion is completely non-negotiable early on. I mean, without proper load management, that tissue is simply not going to heal.
Now, I want to flag a few things as open clinical reasoning points. When it comes to electrophysical agents, there is zero firm evidence supporting their use for this condition. And things like manual therapy, external physical devices like MCL taping, or specific splinting protocols, they remain open questions in the literature. There's really no textbook answer here, so this is where your professional judgment, based on the patient's presentation and irritability, really comes into play.
When you get into therapeutic exercise, your primary mechanical goal is pretty straightforward. Strengthen those wrist flexors and forearm pronators. These muscles act as dynamic stabilizers for the medial elbow, effectively offloading that healing MCL. You'll want to progress from general strengthening into function-specific shoulder and elbow positions. Make sure you really emphasize eccentric control, and eventually you can integrate structured frameworks like the Thrower's 10 program.
Once the tissue is ready to handle it, you'll shift gears into specific power training parameters. We're talking 8 to 12 reps, 3 to 4 sets, really focusing on high-velocity movements for both the wrist and forearm, as well as the shoulder and elbow complexes. But strength isn't everything. You also have to correct their throwing biomechanics. A classic flaw you'll see is a patient rotating out of the late cocking phase way too early. That puts massive valgus stress right onto that medial elbow, and you have to fix it. Finally, graduating back to activity means starting an interval throwing program. But listen, this isn't just some calendar you print out and hand to them. They have to meet strict physical criteria just to begin. Full range of motion, minimal pain, and sufficient strength and dynamic stability. From there, you progress them without a fixed timetable. Let the tissue response dictate the pace. And the golden rule you must drill into their head: if they feel any sharp pain, they stop immediately. No exceptions.